Good afternoon. My name is Andrew Bluestein, Vice Chairman of Garfunkel Wild, and I want to welcome everyone to our webinar today. The webinar's title is Resolving Payer Obstacles, and given the amount of people who have signed up, something tells me that people are having obstacles with payers. So hopefully today you will learn some strategies on how to deal with that. Before we start and I introduce our speakers, let me just run through a quick commercial. The first is for our firm, Garfunkel Wild. Many of you who have signed up are already clients, so you know that what we do is we are counsel to the healthcare industry, and we have offices in New York, Connecticut, and New Jersey, and we can help you with all of your legal needs. And also, this is a joint presentation. We have Grassi Healthcare Advisors, LLC, who is promoting this with us. Grassi supports organizations in achieving and maintaining revenue integrity performance. We have used them very often. They're excellent at educating providers, at helping mitigate risks, dealing with payer audits and overpayments, and we're very pleased to partner with them because we consider them experts in the industry. Also very important, and this will end the commercials, but this is an important one. This is our second webinar leading up to our November 1st ASC and Healthcare Management Symposium. People are registering, and we appreciate that, and sponsors are also signing up right and left. What we're going to do for today, for everyone who has registered for this symposium, is we're going to offer you a 24-hour discount. If you want to register, you can get on to the website that says info. Actually, no, you can get on, the website is nymetroasc.com. You add the discount code, and you're going to need a pen for this one, NYM, which is New York Metro, NYM GW19, NYM GW19. If you put that in within the next 24 hours, it will be a $65 discount for the one-day symposium, and the cost will then be $285. If you want to see the agenda, it's there. It is a very packed day, and you'll learn a lot about ASCs and healthcare in general. Okay, so now on to our panelists. So the first presenter will be my partner, Debra Silverman. Debbie is the head of our managed care group. She has a wide spectrum of areas that she covers, and she is a wonder, and we deal with her. There's a two-headed monster. We have her and Roy, who I'm going to introduce in a second. But if you have questions at the end, Debbie's contact information is there, and she can really help guide you out of a lot of problem areas, but also give you proactive advice before problems start. The second speaker is Alicia Shickle from Grassi. Alicia has been around for a long time. In 33 years she's been doing this. We use her all the time as well. She's a senior manager for Grassi Healthcare Advisors, and she really specializes in educating providers, in making them understand what they're doing right and wrong, in revenue cycle integrity, and she is a tremendous asset, and we're very pleased to have her today. Prior to joining Grassi, she has a long list of accomplishments, but she served as the Director of Compliance for the world's largest training and credentialing organization with more than 175,000 members. And she seems to be the Director of Coding for just about every organization that exist in the United States. So we're extremely happy to have her. And then following up, after Alicia's done, is Roy Breitenbach, who will finish up the presentation. Roy is one of the heads of our litigation department. He's a tremendously skilled trial lawyer with many years of experience in both healthcare and commercial litigation. But Roy really has a subspecialty in dealing with / attacking / suing managed care companies. So if the duo of Alicia and Debbie do not cajole and get you where you want, Roy is a tremendous advocate for all of our provider base. And with that, I'm excited to hear what they have to say, and I will turn it over to Debbie.
Thank you very much, Andrew. I just did a quick calculation, and among Roy, Alicia, and myself, we have over 85 years of experience in dealing with payers. So I hate to admit to being that old, but it's true. So let's talk a little bit about today's issue, and that's dealing with managed care payers. Although we're focused on ASCs in light of the upcoming symposium, really what we say applies to all types of healthcare providers. And as you know, I think most of you know, the days of not having to deal with managed care payers is long gone. I'm seeing now even those specialists who never had any need to be PAR are calling and saying, hey, I need to become in-network. The world's changed with the New York Surprise Bill and other types of pressure that is being put on the industry to drive business in-network. Specialists like plastic surgeons, orthopedists, super specialists like in bariatric surgery, they are all reassessing and determining it's time to go PAR with the plan. You know, we hear all the time that the managed care companies, they're the devil. It's always one-sided. I can't take it anymore. There's got to be a better way. And I'd like to tell you there is, if you're prepared. It's not essential. They're not going anywhere. Regardless of everyone's political affiliation, even if we were to go to a universal payer or single payer, it's years in the making. So this is what we got for now, and let's see if we can make the best of it. So let's talk about some of the obstacles. I'm going to talk about take it or leave it contracts. Alicia is going to focus on the coding, audit, and the revenue cycle side. And then we're going to end up with Roy dealing with network termination issues and denials and payment problems. I actually tell the plans when I speak to them, they want to deal with me rather than Roy. Roy is clearly our last resort, but he and I often consult if a problem is raised to me by a client. In dealing with strategy, I will often say to him, okay, look, this is where we're at today, because I want to be guided in case we can't resolve it at my side of the office and it kicks down to litigation. Let's just talk briefly about a word about fear. And there are providers who feel that they're afraid to deal with the plan. I don't want to annoy them. They're going to take it out on me. They have all the resources. I'm just David in the world of managed care Goliath. And let's just first set the stage. There's the law and the reality of dealing with managed care plans. I deal with them every day, and I deal with many different types of payers. And I pride myself on having developed very good relationships with most of them. And dealing with provider disputes is part of their job. They don't take it personally, even if you have an issue that is so near and dear to your heart. If you get upset or agitated, they've heard it before. Obviously, we always want everyone to be professional and respectful at all times, but there is no reason not to pursue legitimate disputes with plans. They expect it. How far you'll go on a particular dispute, however, often is dependent upon how much money we're talking about and how important it is and at what level. And you can always start with a prompt pay complaint if you haven't gotten paid before escalating it to a full-blown litigation or arbitration. Remember, it's just business. it's their business, and I know it's your business as well, but it's not. We're not dealing with life or death. You need to have a balanced approach, but be firm. And really, the most important thing is come with examples of what your issues are. You don't want to call up and say, everything's a mess. Be specific as to what the issues are. And you'd be surprised, but if something should be fixed, often a strategically placed phone call can get it fixed. And if they say they're going to do something, give the plans time to fix a problem. They move at a glacier pace often. So while for you it could be your top priority, the person you're dealing with has 50 other providers that they're responsible for. So you try to be somewhat patient, but still the squeaky wheel often does get the grease. Also, don't make empty threats. Managed care plans have long memories. If you threaten them, if you threaten their business, I'm going to go to the Better Business Bureau, I'm going to post on the internet, never to deal with you. I don't like having my clients wage a public war of words against a managed care plan. The likelihood is at the end of the day, you're going to kiss and make up anyway. But just be honest. You have real issues. You've provided services. You need to get paid. So I guess the closing thing about dealing with fear is, remember, it's a relationship business, and establish good relationships with plans. It will never serve you wrong. And the industry is very small. A provider rep who you've dealt with at Cigna, the next week could be at Aetna. And the guy at Aetna could now be over at United Healthcare. So keep those relationships and make them as positive as possible. Let's move on to take it or leave it contracts. You know, contracting, everyone wants to leverage whatever power they possibly have. And unless you're a very large academic medical center, or you happen to be the only healthcare provider in a particular geographic location, the managed care entity is going to have the power in the relationship. It's a fact of life. There are some protections that the law provides for you in New York State. Remember, though, the protections that are in the public health law apply only to the licensed products. They don't apply to what is now about 50% of the business, which are when the plans function as third-party administrators for self-insured plans. So bear that in mind, too, that when you point to a law, the plan will say, hey, it doesn't apply to us. I just hung up the phone with 1199 before starting this webinar, and they make it very clear that nothing in New York State law applies to them. They're governed by federal law, and their regulatory agency that supervises and oversees what they do is the the United States Department of Labor. You know, even when we're talking about take it or leave it contracts, where the plans say, hey, this has been approved by the state or the feds, and we're not changing it. If you can narrow your issues and really make the case for why you need a particular change, you'll be surprised that in negotiating a contract, they'll bend a little. Sometimes, you know, when you're dealing with ASCs, particularly in talking about managed care contracting, the insurer decision-making process really focuses on the impact to their members, the impact to their bottom line. We're now seeing in the industry a return to the narrow networks. They don't need as much access as they thought they had. What sells now is price. To the employer groups who are buying these plans, they want to make it as cost-effective as possible. And if a provider in a narrow network will get more volume, they're willing to give up a little bit more on price. So you have a situation now where the plans are coming in with really lowball reimbursement terms. New York State law does allow a plan to change the fee schedule on notice, as long as they give 90 days written notice. and they're looking to provide contract terms that are really very beneficial to the plans, right? They want the ability to amend on notice. They want the ability to find whatever they can to not have to pay for a claim. Either it's an administrative denial, you didn't dot the I and cross the T. So those are things that we try to look for when we're negotiating a contract to protect the provider. But you should know, though, you're not powerless, okay? You definitely have the ability to negotiate contracts. And the one area that you may see is, can you offer a lower cost, high quality option to the plan? And we're not going to talk today about value-based payments and what those types of contracts look like, but here's another advertisement. But at the ASC Symposium in November, we are going to be spending an entire session dealing with value-based payments. So to learn more on that, come to the seminar. But getting back to the ASCs, what you can do to show to the plan your market value. Do you have a loyal referral network from physicians who like to use your ASC? If you're not participating yet, many of these members have out-of-network benefits, and they can access the ASC through their out-of-network benefits. Just a caveat, make sure the members understand and acknowledge in writing if they're going to be using an ASC with an out-of-network benefit, that they understand it in advance. We have been seeing some very draconian language in managed care contracts lately about participating providers who refer to an out-of-network location. There are some boilerplate language in there that says, if the patient doesn't know about it, you, the referring provider, are going to be responsible to pay. When I have the opportunity to negotiate these contracts, we get that kind of stuff out. And the plans usually do agree to take it out. It's interesting. But if you haven't read the contract and it's in there, buyer beware. So let's talk a little bit about negotiating some of the pitfalls. The first thing that you need to do, even in a take it or leave it contract, read the contract. You'll be surprised how many times a provider will, have all the degrees under the sun, extremely intelligent people, and they sign on the bottom line. If you do that, that's the risk that you take. At a minimum, even if you can't negotiate, we can at least explain what are the risks in this contract, what do you have to look out for, what are the time periods do you have to submit a claim, to appeal a claim. These time frames, as Roy will discuss later on in the presentation, are firm. If you miss a timely filing, let's say you have 120 days to submit a claim, and you submit the claim on the 121st day, you cannot get paid for that claim. It is as simple as that, unless a narrow exception, and it applies under New York state law, and you actually meet that exception. Another thing that you need to know, what are you getting paid? That's not your charge. It's whatever the fee schedule is pursuant to the contract. There's amazing software out there. If you don't have that software, which you can basically load into your system to know what the amount that you should be getting from the plan, so you know if you're being properly paid, or are you being underpaid, or are you being overpaid, that does occur, believe it or not, on a not so rare basis. It's imperative that you invest in that, and Alicia will talk a little bit more about what you need to do to manage your revenue cycle. But again, know the terms of your contract, know what you're due to be paid under the contract, and lastly, and perhaps even most importantly, know what obligations you have under the provider manual. Every contract is going to refer you to policies, procedures, protocols of the plan, and you are obligated to abide by them. Again, when we're negotiating a contract, we try to negotiate protections against changes to the provider manual and the policies, but at a minimum, know where you're starting today. I used to tell clients when managed care first came into being, on every Friday morning, take a cup of coffee, sit out by your computer, and just go through the websites of your major payers to see what changes did they enact. Sometimes there'll be none, and sometimes you'll be surprised to see what changes are there. Often you might get an email blast. Make sure those email blasts are not going into spam. You need to stay on top of what the plans are doing through their policies and procedures. And lastly, and I'm going to hand off now to Alicia, get your house in order. Because even if you follow all the rules and you're getting paid what you're supposed to get paid, auditing by managed care plans is taking up a good third of my time now. So they can come back. Under New York state law, they can come back 24 months. If they're alleging any type of abuse of billing, they can come back 6 years. Under federal plans, they can come back 6 years unless you've shortened that time period in your contract. And they're going to ask for medical records, and they're going to do an audit. So with that, let me pass the baton over to Alicia.
Thank you, Deb. So I have trouble getting rid of this slide, which is my little crazy kitty, because we think of this dealing with revenue cycle management, but of late I've been thinking to switch maybe this picture up to a bear, because the revenue cycle in general sometimes can be a bear. Two things I really just want to echo on what Deb said. You know, it's so crucial to understand your payer-specific requirements for all your government, for your managed care, and your commercial plans, for both in and out of network participation. And if I can add one thing, I would say, once you have your contract in place, please put it somewhere in a safe location that when we need to refer back to it, we can find it. Unfortunately, many times we find that we are assisting clients with revenue cycle. We need to see what the actual requirements are within the contracts, and many times they're not available. So I just want to reiterate that. They are very important to have. Okay, revenue cycle integrity. What does achieving that do for us? It increases our income, believe it or not, as long as you're monitoring, making sure that you are not only billing for things that you shouldn't be, but also capturing all of the services that you are rendering. So that's crucial for increasing your income. It decreases your risk, right? It minimizes the risk and exposure to RAC audits, to payer audits, hefty penalties. And it also makes sure that you're in compliance with regulations and payer requirements. And all of this, in turn, equates to better patient care, which is the most important component. Why is revenue cycle integrity so important? Because there is an expectation of compliance, right? So just because you're getting paid doesn't mean you should be getting paid. Many times there are no edits in the third-party payer systems. Claims will get through. Modifiers will open the floodgates, let the claims through, even though they shouldn't be paid. In today's world, it's not about getting paid, it's really about staying paid, right? We talk about today's oversight is all about big data. We had some conversations on this yesterday. The government, the payers, they have the ability to look at your data at a macro level, and they do. The OIG has individuals who are hired specifically just to do that, right? So that's all they do. They data mine. They look for outliers. They look for patterns. They look for trends. They look for inappropriate coding and improper payments. So when we talk about assessing and achieving and implementing and maintaining revenue cycle integrity, we really want you to avoid being a target in those situations. And this doesn't work anymore, right? So these are the 5 statutes that help comprise the Medicare fraud and abuse laws. We have your False Claims Act, Anti-Kickback Statute, Self-Referral Act, otherwise known as STARK. We have the Exclusion Statute and the Civil Monetary Penalty laws. These laws are enforced by the Department of Justice, HHS-OIG, CMS. And don't think just because these are more government, they make up the Medicare fraud and abuse laws. The commercial plans are also, you know, they're looking at all of this stuff as well, and they will be contacting you. Again, the False Claims Act, no intent is necessary. It's not whether you knew, it's whether you knew or you should have known, and there is a wide array of information out there. So the payers expect that you know what is required of you. Anti-kickback statute, a lot of providers say to me, how does that impact me? I don't know. Well, you need to make sure that you are collecting deductibles, that you are appropriately collecting co-payments, and that you are following up properly on patient payment responsibility, right? Exclusion, providers, unfortunately, we see a lot of providers facing exclusion. When you're excluded from participation, basically you can hang up your shingle because no one is allowed to do work with you in the healthcare field. So that can be devastating. And then the civil monetary penalty law, again, providers facing hefty penalties and fines. Achieving revenue cycle integrity, maximizing an M-Surge revenue requires a comprehensive approach to examine the accuracy of your coding, your billing, and your reimbursement processes, right? So we've laid out a few of those processes here. But I want to talk about coding, right? Accurate coding. Making sure in the M-Surge centers, one of the most key components is to make sure that you have comprehensive op notes from your providers. One common error that we find is that the coding is done from the procedure description instead of the content of the note of what really happened, right? So it's crucial to make sure that you're coding from the note. And while having certified coders is not necessarily a requirement, it's a best practice, and it's crucial to have people who are in your notes, analyzing your notes, deciding what code should be built, people that are educated. So certified coders, I think, are key to getting integrity there. Make sure you're providing ongoing education for your staff and your providers. I can't shout this enough from the rooftop. As soon as we get something down pat, things tend to change in our industry, right? So make sure that you're up on all of your requirements, all things that are applicable to your type of organization. And then internal and external reviews, again, policing yourself internally, making sure that your documentation is thorough. And honestly, it's like your first line of defense if you're ever under a third-party audit, right? I can't tell you how many times providers are audited and the documentation is just not there. And the providers say, well, I did it. But we all know, we've heard it a million times, if you didn't write it, you didn't do it. And again, like, your documentation is not about quantity, but about quality. So we talk about developing templates, but making sure that those templates are not putting you at risk, right? They need to be customizable. Every encounter needs to be unique, right? Don't copy and paste. We talk about that as a risk here. Making sure that your notes don't look like you've been cloning, right? So that's a big area. I don't know, Deb, did you want to?
Yeah, I just wanted to just add that if it's not in the record, it didn't happen. So Alicia is not understating it, overstating this. In fact, you could argue she's understating it. I just want to tell you, I've had 2 recent experiences with audits. One audit, the original demand was close to $1 million. Because of really good documentation, we were able to bring that audit down to be resolved for $13.67. So that's the good news. The bad news, 2 weeks later, we had a demand for $700,000. And we poured over the documentation in many different ways. And we just got the result back, and we were only able to reduce the audit by $50,000. So the documentation is everything. I just want to second what Alicia's saying about cloning and templates. I know with EMR systems, it's very easy just to keep replicating the note, but you need to customize that note for the individual. And just a word of warning, make sure when it comes to time-based codes that you are actually putting the number of minutes. It is not enough to write, oh, we did it for 1 unit. Make sure if it was 7 minutes, 8 minutes, 12 minutes, whatever it is. So that's my newest issue that I'm dealing with now on a lot of these audits. Thanks, Alicia.
Yeah, sure. Again, and we just want to, kind of hone in, make sure that, when we talk about the accuracy of your CPT codes, make sure that the codes that you're submitting most accurately reflect the services that you're providing, right? Was it arthroscopic? Was it open? There's a huge difference in those. So you may look like the same procedure, but one's arthroscopic, one's open. Huge payment difference, right? Just a note, making sure that you're not unbundling for packaged items, but you also want to make sure to capture all the separately billable services. So do your homework, know what codes you're submitting, know what services you're providing. And then, we talk a little bit about diagnosis coding. We know now that we're in ICD-10, everything has to be to the highest level of specificity. Don't submit codes when you're doing a procedure that has unspecified laterality, because that's a big flag to the payer that you're either messy, lazy, or there's an indication that maybe something's going on and you're not really sure what you're doing, right? So you know that you're doing surgery on the left knee, make sure you use the right diagnosis code. Don't submit a code for unspecified limb, unspecified knee. It's definitely not good for you. Modifiers, we talk about modifiers. Making sure that modifiers are appropriate, and again, payer specific. A lot of the different payers have their own requirements on how they allow or they don't allow modifiers, right? Especially those modifiers that trigger payment. Modifiers are 2 digits that you put on your claim that send additional information off to the payer, like, hey, we were doing this procedure and for some reason it was discontinued, so we're letting you know that with a modifier, or these services were separately identifiable. Make sure specifically, if you're using modifiers that trigger payment, that your documentation backs it up and that you're using them appropriately. Okay, auditing the claims management process, right? This is another huge component of the revenue cycle. We're talking about coding, we're talking about documentation, we're talking about EMRs, but we really need to make sure that we're also keeping track of the revenue cycle process, right? So don't underestimate how important it is to get all the demographic information in the system appropriately, insurance verifications, any prior authorizations, right? These things all impact payment, right? Make sure that your charges are posted correctly. Diagnosis codes are linked correctly. It's crucial. Otherwise, you're going to start seeing denials, right? And then monitor your days, the number of days to generate the claim after you receive it from the coder. Deb talked about your contracts and timely filing, and we're going to talk a little bit about, time limits on appeals, but make sure, don't lose out for timely filing because you're not getting the documentation and you're not getting the codes back from the coding department on time, right? Audit your payment posting process. Again, when we have providers under audit, or worse than being under audit, when they have accusations, false claims accusations, or providers are getting accused of fraud. We've been seeing more and more in the industry, things that one might just perceive as a routine error. Providers are actually now being charged with healthcare fraud and forced to defend themselves in those actions. So again, having all of those things up front, your coding, your documentation is crucial, but also having the ability to go into your own practice management system and say, yeah, we charged this, we were paid this, we adjusted this off. I can't tell you how crucial that is, right? Not only does it impact your compliance, but it also impacts your finances, right? It's impossible to budget, to plan, if you have no idea what's been paid and what's been owed. And one thing I want to say about adjustments, I think it's crucial making sure we talk about, you're spending all this time and effort, negotiating your contracts, your fee schedules, your allowables are part of those contracts. And it's important to incorporate them into the revenue cycle process. Monitoring your adjustments. If your staff are just writing off balances, it may not be appropriate, right? You might be leaving money on the table or losing money. So it's really important to keep on top of those. Also, we want to talk about credit balances, right? The Affordable Care Act has this 60-day overpayment rule. You have to pay that money back. We had a situation last week where we have organization who's looking to sell their practice and going through the finances, they notice there are a lot of little credit balances, right? There is an obligation to pay that money back. So don't get caught up in that, well, we'll just kind of hang on to it and we'll see what happens, because if they deny us later or they underpay us, it's going to balance out. It doesn't work like that. That's a big risk. Okay, follow-up. Make sure that you're, one, submitting in timely, and two, you're following up timely, right? You don't want to leave money on the table and lose revenue that you're entitled to because you're not applying enough resources into your follow-up. So again, if claims are denied, you should really be keeping track of those denial reasons, manage that. And again, we always say, go back to the root cause. Don't put a Band-Aid on those things and just fix them. If you're getting denied, you should know why you're getting denied, and you should be fixing them at the source, right? Following up timely, making sure that if you have something that you can appeal, that you're doing it, understand what your provider requirements, your payer requirements are, as far as timely appeals process. Again, effective AR management, it assures that your billing issues are addressed timely. We cannot stress that enough. Implementing your compliance program really is going to help you stay on top of this. You don't want to find out later, somewhere down the line, because you're not monitoring these things. Oh, well, we've been overpaying you on that code for 5 years, and now we're going to come back and we're going to do a take back on all of that. Guess what? It happens. And it's unfortunate, and it can be financially devastating. So keeping on top of all of that. Identify trends and issues with your payers. Do your payer mix indexes, right? Pull those key performance indicators, not only looking at your AR, but looking at your payer mix. Again, looking at your denials. Monitor yourself internally, because you know the payers are looking at all of that claims data on the back end. Right? Make sure that your denials are resolved timely. Again, avoid delays in cash flow and lost revenue, right? So it helps with that. And again, I just really can't stress enough, just get back to the root cause of the issues and fix them. And sometimes that goes a long way. Like in the world of compliance, we always say, like, if you're not finding things, then you're probably not looking in the right place, because the world we live in is so complex and so complicated. So keeping on top of all of your things, looking for problems, fixing those problems goes a long way if you have an issue later on. Show that you have an established program and that you're putting yourself in there. Okay, turn this over to Roy.
Okay, so thank you very much, Alicia and Deb. I'm going to talk about topics for more of a litigation or a dispute resolution component. What I do is handle and hopefully successfully resolve disputes that healthcare providers have with the payers. So our first goal is always to try to resolve the disputes quickly, efficiently, and as cheaply as possible. But we all have to understand that it definitely is a strategy sometimes with the managed care companies to do a war of attrition. So I'm going to talk about some of the issues and some of the things you can really do to kind of prepare yourself for battle and to hopefully avoid the battle by good preparation. The way I think it's useful to look at these topics is kind of divide them into two issues. These are where most of our disputes come from. The first one is the concept of network termination, and the second one is basically underpayments and late payments. With regard to the issue of termination, it's very important to realize what's going to happen if your contract terminates, right? You have to understand at all times when we're talking about network termination decisions, and that's whether or not it's the managed care company that's terminating you, or whether or not it's you who are deciding to, if you don't like the contract, to terminate it yourself. You really have to make a decision as to what it means. And I think Deb shared a little bit about this before, but the key thing is to understand how the plan reimburses out-of-network providers, and the realization that the days in which out-of-network providers are being reimbursed as a percentage of the usual, customary, and reasonable is long gone. Most managed care companies bill reimburse on the basis of a percentage of Medicare or some other percentage, which yields a much lower reimbursement rate than the old-fashioned UCR reimbursement. If you talk to the payers, they'll tell you that the reason why they went to the Medicare reference is because it eliminates disputes over what the UCR is, and that's true, but it also dramatically decreases what your out-of-network reimbursement rate is going to be. You also have to understand that when you are out-of-network, there's a delay in payment. Varies from payer to payer, but there's certainly a delay in payment. There's also the issue that the managed care companies can then send the checks, the reimbursements directly to the patients, and you're going to have to chase the patients. The other thing you have to understand about out-of-network is most managed care plans now have anti-assignment clauses. And while we fight them, what the anti-assignment clauses mean is that the managed care companies will not recognize when their members assign their benefits to the out-of-network providers. So as a result, it means that the managed care plans won't talk directly to the out-of-network providers. The out-of-network plans have the out-of-network providers have a very difficult time pursuing appeals on behalf of their members, and have a very difficult time pursuing litigation or arbitration on behalf of their members. Anti-assignment clauses, it seems that every managed care company is putting them in their plans, and as they're attacked and as the language is criticized by the courts as being vague, they've been tightening them up. The other thing, obviously, you have to worry about concerning out-of-network is the obligation to balance bill and dealing with the routine waiver of patient obligations, which is always an uncomfortable conversation. There are exceptions for emergency treatment. Those emergency treatment exceptions probably won't apply in the ASC context, but they'll apply in other contexts. Those are very murky, and there's been a lot of litigation over them. I know people believe that just because it's an emergency, an out-of-network provider can kind of dictate the fee, and that's no longer the case. There are a lot of rules about that, and it's a complex area. And then, of course, what you have to do is you always have to go to the concept and worry about the concept of excessive fees, right? There's a lot of issues regarding managed care plans taking the position that the fees that are billed by out-of-network providers are excessive. Oh, there's nothing in New York that prevents you from billing whatever you want, charges whatever you want. You do get a lot of pushback from providers, and it is a trigger for providers to go in and to put you on prepayment review and things like that. So it's an area that you have to be pretty careful about. There's also the issue now of, and it's particularly true with regard to ASCs, is that managed care companies have been employing various strategies to discourage or prevent referrals to all out-of-network providers, but, pretty particularly ASC facilities that are out-of-network. They do these through various provisions. First provision is to require pre-certification, and then through the pre-certification process, use subtle or not so subtle strategies to steer them away from out-of-network facilities, particularly with elective cases. Number two, adopting contractual provisions which penalize the referrer for referring out-of-network, such as making them liable for any out-of-network fees or fees above the in-network rate, or saying that they're going to place referrers on focus review because of excessive referrals to out-of-network providers. So that's a big issue. And then finally, sneaky clauses in contracts that say when you refer, when you refer to an out-of-network provider, the out-of-network provider, when they accept the referral, is agreed to be paid at the in-network rate. Those clauses, we think from the out-of-network side, are probably not that enforceable, but nevertheless, it engenders a huge fight. It's something you have to be worried about. So let's talk about the nitty-gritty of provider network participation, terminations, and disputes. Okay, a lot of disputes revolving the managed care companies coming in, deciding that they want to have a narrow network and picking and choosing what providers they want in the network, sending termination notices to those providers that they don't want in the network. And there's not a lot, unfortunately, that providers can do to challenge these types of decisions. If you take a look at your agreement, they usually have the right to absolutely non-renew at the end. They do have the right to terminate for various reasons. Oftentimes, there's a termination without cause provision, but you have to look at your agreement to understand what it says. Very often, they don't have to provide a reason for the termination, particularly, obviously, if there's a termination without cause provision, and there's a very streamlined process for terminations and non-renewals. The distinction between termination and non-renewal is a huge distinction with regard to network participation. While most providers don't pay all that much attention to the term provisions in managed care contract, it's very important for the purpose of network participation termination. If you're terminated by a managed care company at the end of a term, so that's essentially if there was an initial 3-year contract, and at the end of the 3 years you get a notice that they're not going to renew you for another 3-year term or 1-year term or whatever the successive term provisions of the contract say, then that's technically a non-renewal. And you usually have far less rights to challenge non-renewals than you do actually terminations in the middle of the term. In fact, under New York law, you virtually have no rights to challenge a non-renewal. So it's a very important distinction and one that you have to understand. Now, based upon the nature of the plan, where you practice, and whether or not it's a Medicare or Medicaid plan, there may be some type of an appeal mechanism to challenge a termination. And, we encourage our providers to do it. However, there's a lot of pitfalls. There's usually a very short time frame by which to do it. Usually, the managed care company is overwhelmed by appeals, particularly if they're going through a narrowing period. So as a result, you're going to wait a while for the appeal to be decided. Generally, they try to push you into an appeal on the written record rather than some type of a conference call or in-person appeal hearing. So you got to be careful about that, because usually we find that the ability to talk to somebody live at the managed care company through some type of either telephonic or in-person appeal stands a better chance of being successful. But the reality is that very few of these challenges are successful because the appeal mechanisms are a stacked deck in most cases in favor of the managed care company. They're usually internal managed care company personnel that are making the decision, and they basically could just say it was a business decision and that's it. When we have been successful in challenging terminations, it's by developing a non-adversarial record about the value that this provider brings to the network. And it's a sense that, we understand you terminated us, but did you realize, and then, how much money we're saving you, how we're the greatest things since sliced bread, how all your in-network people refer to us, how we're unique, how, usually sometimes language issues, like, for example, you're the only provider who speaks Turkish in a Turkish neighborhood, for example. You do all these things, and you usually, that's the one area that is successful. So what we usually advise providers when they're in a network termination challenge is to be less adversarial with managed care company and kind of develop a strategy of saying, hey, here's what you missed about us, and here's why we're great. And so that's something that we'll throw out there. If you lose the appeal, it's very difficult to challenge it in court. Sometimes an actual termination in the middle, you can challenge in the middle of a term. Excuse me, but if it's a non-renewal, it's almost impossible to challenge. There are some complicated ways of doing it based upon the reasons, and you should have your counsel look at it, but know that the availability of legal challenges are going to be very difficult. Let's go now talking about the collateral effects of termination. Very important, okay? I know sometimes with some providers, there's a belief, well, if they don't want me, I'm just going to accept it, move on, forget about it. You have to understand what the collateral effect is going to be. Are you going to have to report, is this going to be reportable to the data bank? Is this going to be reportable to OIG? Are you going to have to put this on your medical staff privileges reapplication? What are the patients going to be told about the termination? These are all things you have to think about and you have to deal with. And what I will say is that oftentimes, even though the provider is not going to challenge the fact that they were thrown out of the network, oftentimes a lawyer can negotiate with the managed care company certain protections to ameliorate the collateral effects by saying that we'll all agree that it was a termination without cause or it was a non-renewal. And you can navigate some of these thorny issues. There's some reportability concerns that are difficult to negotiate away, but oftentimes we can help in navigating that complex to minimize the collateral effects. So let's now go on to just, the last thing I want to talk about in termination is, here's what the key issue is for termination. Bottom line, when you're dealing with the managed care company, it's whether or not it's more expensive for the managed care company with or without the ambulatory surgery center in network. We usually down to pure dollars and cents. And if you could show that in an appeal, you're going to have a good chance of doing well. Let's now talk about late payments, underpayments, and technical denials. So that's what we usually challenge, okay? And so let's talk about what the three kind of terms mean. A late payment is a payment that's beyond what you expect under the terms of either the contract or, like, for example, the New York State or the ERISA prompt pay law. And those issues usually turn on how is a clean claim determined. When did the provider submit a clean claim? How long does the managed care company have to review the claim? And so we have a lot of challenges to late payment, but the bigger challenges that we have are to underpayments, right? You're not getting paid at all, or you're getting far less than you expect. We do a lot of challenges on that basis. The key to those types of challenges is to understand really what the data is. I can't tell you how often I have clients come to me and say, we've been underpaid, we don't understand why, we think that the managed care company is doing something wrong. When you actually look at the EOBs and the way things were billed, you find out that it's really a mistake on the provider's part. So you really have to understand, when you get a bill in I think Alicia and Debra have talked about this as well. When you get an EOB in your shop and you're paid for a procedure consistently less than what you expect, the key thing to do is to start early to understand why it's happening. That way we can avoid a lot of litigation. And it's the same thing with technical denials. You're getting denied for technical reasons, it has to be escalated in your organization to somebody who can determine and understand what the reasons are and correct them quickly. So, here are some of the disputes that we frequently see. So the first one is managed care company errors. Sometimes there's just disputes and there's underpayments because the managed care company makes an error. Happens a lot when there's mergers and acquisitions. It also happens because of overwork or understaffing. A lot of our things we see, they're just processing the claims incorrectly. Confusion or ambiguity about what applicable rate applies. A lot of confusion or ambiguity, particularly with rate sheets. Sometimes they're very difficult to parse, and oftentimes, managed care companies can take advantage of that. So there's a lot of information, there's a lot of issues surrounding that. The other big issue is pre-certification. Obviously, if you don't pre-certify, you're going to have a lot of issues, and that's something that's relatively easy to correct, at least on a going forward basis. Failing to submit clean claims. You need to submit clean claims. If you don't, you kind of give it an avenue for the managed care company to come in and raise issues and problems. A lot of issues, as Alicia has explained, about documentation issues. Poor documentation causes underpayments and non-payments, and then it's difficult sometimes to correct them. If you're providing a new or cutting-edge service, there's oftentimes disputes with the managed care company about what rate applies. And I see that more frequently, and that's something that we really have to sit down with the managed care company and understanding where they're coming from. And in certain circumstances, you may have to bring some type of a dispute resolution proceeding to resolve that. Obviously, there's a lot of disputes over audit, as Alicia talked about, and initiatives from the managed care companies. A lot of issues with delayed follow-ups, and of course a huge issue regarding the failure to timely appeal. If you don't understand what the appeal process is for claims and you don't appeal timely, it's very difficult to challenge it later. So let's go on to the next slide and talk about resolving claims issues. Important thing to remember is that time is not on your side. If you're in a situation where you're having a lot of underpayments or non-payments, you need to make sure that you promptly process and post all EOBs and claim payments. You have to thoroughly understand what the rules are. Make sure you're providing all the documentation you need to. Very important, when you start engaging the managed care company about issues, particularly issues regarding underpayments and non-payments, you need to document those interactions with the managed care company in writing. Try to do it by email or send a confirming email with the managed care company so there's a paper trail. If you're dealing on the phone and you don't have any emails or anything, and you can't communicate an email, at least have contemporaneous notes so that there is a paper trail that we can use later if there is a dispute as to how things happen. Always look for patterns in your denials, because you'll see patterns and issues will come to the forefront and you'll understand the issue better. And a better defined issue is an issue that's easier for us to resolve through the dispute resolution process. Carefully escalate the issues, right? If you're not getting satisfaction on one level in the managed care company, go to the next level. And finally, be very, very careful about a strategy for the managed care companies playing out the clock. They play out the clock because they'll continue to say they're looking into an issue, and they'll let time run out because they'll think you'll either go away or you'll blow deadlines. So you have to set firm deadlines when you're dealing with the managed care companies and be prepared to escalate if you don't get satisfaction. It is very important in any of these disputes to get the professionals, the lawyers, the coders, the consultants involved early, because the dispute can be shaped by those professionals. Okay, if there's too much back and forth between the provider and the managed care company before the professionals are involved, sometimes it's difficult to get everything back on track. Concessions may have been made, agreements may have been made, and it's difficult to undo them. You need to put your house in order first before you're going to escalate, right? Make sure you're collecting co-pays. Make sure you're doing everything you need to do. Make sure you're properly coding. Make sure everything is in order. Because if the managed care company starts to believe that they're wrong, they're going to fight back. They're going to try to find something on the provider side that they can attack to kind of deflect attention. So it's very important to put your house in order first. You also have to gather all the facts. So many times disputes come to us and we get the provider's story about how they're not getting appropriately reimbursed. When we actually look into it, it's a problem for the provider. Start small, raise issues carefully, don't overstate them, and then build with the managed care company if you don't get satisfaction. Give them reasonable deadlines for response. We need you to get back to us in a week. We need you to get back to us in 2 weeks. So that way, if they consistently blow those deadlines, you have an ability to, or excuse as to why you're taking it to the next level. Don't make empty threats. If you threaten to go to litigation, if they don't respond, be prepared to go to litigation. The worst thing, as Deb talked about before, is handling empty threats. Finally, there's a 70%, there's a 70-30 rule in all of this, which means basically that, it's about 70% effort that you should focus on the top 30% of all of your claims. And you should deal with that, and you should focus on that. So let's go now to the next slide and talk a little bit about more principles of escalation. You need to know your deadlines. Very important. So many disputes are destroyed or undercut by missing deadlines. So you need to absolutely know your contractual deadlines when you're heading to the dispute. It also matters what forum you're going to raise that dispute in. We always have a conversation at the start of a dispute. Does it make sense just to file a complaint with the health department or the Department of Financial Services or the Department of Labor under ERISA rather than go to litigation? It also depends upon what's the forum for litigation. If you're a participating provider and agree to arbitration, you can't go to court, and there's pluses and minuses to that. It may be very expensive to pursue arbitration. You may not want to do litigation because you're going to be dragged through court for years. So those are all issues you have to have. Again, it's factual detail is key. And finally, we start right away with an intelligent discussion with the provider as to where do you want to be in settlement, because it's purely a cost-benefit analysis. As Deb said at the beginning, this is business. And while there are some emotions surrounding all of this, we all know that providers feel strongly about the need to get paid. The reality is that these cases come down to a cost-benefit analysis. What am I going to get if I challenge it, and is it worth the amount of money I'm going to spend to get there? So we're constantly talking about that. So that's basically a quick run through these issues. At this point, I'm not sure we have time for any questions or. Okay. So yeah. So we're just waiting to get the questions. One question on all of this is, and here's a question that just came up, is how frequently do you see problems with late payments in terms of being able to challenge late payments? And the answer is that we recommend challenging late payments. We've had problems sometimes with going through the prompt pay law. The prompt pay law doesn't apply to every claim. As Deb has talked about, it doesn't necessarily apply to ERISA claims, and the ERISA entities are very difficult to deal with on late claims, on prompt pay law and late claims. But we have used the prompt pay law to really act as a hammer for commercial insurers here in New York to get them to pay attention to the issues and to get them to properly pay.
Roy, let me just add, there's a little trick in dealing with the prompt pay law. It's on the Department of Financial Services website. The key with inflicting gentle pain on the managed care plan is to submit one claim at a time. Drip, drip, drip. If you submit a spreadsheet with 100 claims, that will count as one complaint when the Department of Financial Services assesses a managed care payer. If you do a couple of claims a day off that spreadsheet, each claim is a separate complaint. So take someone from your office, let them submit 5 claims on Monday, another 5 on Tuesday, and you'll be amazed at how quickly you'll get attention. Make sure that you've scrubbed those claims, though, and you know that they're legit. And again, if they are claims for self-insured, they're going to be bounced. But for Medicaid business, commercial business that's licensed under Article 44 of the public health law or the insurance law in the state of New York, it's a great mechanism to do, and it really is all online. I think with that, we are out of time. We apologize for running a little bit over. Again, we want to just let you know about our symposium. Again, we want to give you that code.
It is NYMGW19. That's NYMGW19, and it gets you a $65 discount. I think it's 24 hours. And just want to also let you know that we're going to be sending out to all registered attendees an email that's going to contain a link to the audio file and the materials regarding this presentation. So thank you, everybody.
Great, thank you.